What?
So we are good to start, sir. With all your due permission, can I begin with the session?
Okay, start.
Good evening, everyone. This is Batul, the assigned moderator for today's session, and I would like to welcome all the participants who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. And he is none other than Professor Dr. Bharat J. Parmar. With much pride and honor, I would like to welcome Sir at our platform. Sir is MD, DHA, FAIMS, Professor and Head of Pediatric Department at Zydus Medical College and Hospital. With the help of Sir, we'll be taking a close look on today's topic, which is pediatric hypertension. Before moving on to today's session, let us have a brief look on what the topic says. Pediatric hypertension is a significant and growing health concern. Recent investigations have revealed an increase in the incidence of pediatric hypertension, which was previously believed to be rare in the pediatric population. This increase is partly attributable to the obesity epidemic. Early diagnosis and treatment of hypertension are crucial since it typically persists into adulthood and is a risk factor for both the progression of renal disease and cardiovascular disease. So today we have Professor Dr. Bharat J. Parmar, sir, with us, who will be giving his precious talk on this topic. I would like to welcome sir on our forum. Sir, the forum is all yours. Please proceed with the talk.
Okay. Good evening to all. First of all, I am very thankful to IGCP group to highlight my views regarding the newer subject. There is a pediatric hypertension. So there is no change. Hello?
No, sir, it's not changing. You change it again, sir? You can click on your mouse as well, sir, to change. Just click on your mouse to the next option. It will get changed. See, there's in your screen, you will be yes.
Okay. So why today's lecture on pediatric hypertension? I did work for 2 years in 1980s, about 51 patients of hypertension in children from VS Hospital, Gujarat. I was first at that time at Gujarat, and I presented 6 uncommon cases. That is, there is a Takayasu disease, coarctation of aorta, pheochromocytoma, chronic renal failure, nephrosclerosis, and the renal artery stenosis. So at that time, my remark was the pediatric hypertension most common is a secondary one. Second, it is acute transient. Third, it is renal first, and second, renovascular. So hypertension in children and adolescents is increasing, and its rational management is more intensely reached now than ever before. Remedial cause of hypertension needs to be identified and appropriate remedial measures, surgery for coarctation of aorta, renal artery stenosis, pheochromocytoma undertaken. Pharmacotherapy is reserved for control of hypertension. Before such intervention, an essential hypertension for the condition where such intervention are either not fully curative or not producing expected results. Systemic hypertension in children is defined as systolic or diastolic blood pressure exceeding 95th percentile pertaining to the sex and the height specific normal value on at least 3 occasions, 1 to 3 weeks apart. Though not necessarily hypertensive, children with systolic blood pressure and diastolic blood pressure persistently between 19th to 95th percentile are considered as a pre-hypertensive that is at risk to develop hypertension in a later life and need periodic monitoring. Normal blood pressure, systolic and diastolic blood pressure less than 19th percentile for the gender, age, sex, and the height, and the pre-hypertension, systolic and diastolic blood pressure 19th and 95th percentile, and the hypertension, there's a systolic and diastolic blood pressure exceeding 95th percentile on the three separate occasions. According to the severity, hypertension is classified stage 1. There is systolic blood pressure and diastolic blood pressure more than 95th centile, but less than 5 millimeter above the 99th centile. And second, there's systolic blood pressure and diastolic blood pressure more than 5 millimeter that 99th centile. Children with a stage 2 hypertension needs immediate evaluation, while those with a stage 1 must be rechecked after 1 to 2 weeks before the further assessment. Prevalence of childhood hypertension is an increasing over age, mainly due to the childhood obesity epidemic and increasing stress. Small survey among the school children in India suggests prevalence ranging from 2 to 5%. It also known that risk of mortality due to the cardiovascular cause increase as a blood pressure rise. Hypertension and prehypertension in children and adolescents is associated with LVH and pathologically elevated left ventricular mass index value and increased coronary intima media thickness. Further lack of awareness of a normal prehypertensive and hypertensive level for Indian children and poor blood pressure taking behavior among the pediatricians in our country result in underdiagnosis of childhood hypertension. Since hypertension cause multiple end organ damage, IHD and resultant LVH and congestive cardiac failure and peripheral vascular disease, cerebral hemorrhage and stroke, renal failure, proteinuria, it is important to understand its natural history, diagnosis it early and treat effectively so as to prevent or delay complication. What is etiology? Renal and renovascular disease is a leading cause of childhood hypertension, whether transient or persistent. While 90% of the case with the transient hypertension are due to post-streptococcal glomerulonephritis and chronic renal disease is responsible for 3/4 the case of persistent hypertension. Causes of transient hypertension. The renal cause, acute glomerulonephritis, hemolytic uremic syndrome, acute pyelonephritis, renal trauma, and surgery. Neurological cause of hypertension, raised intracranial pressure that is encephalitis, Guillain-Barré syndrome, and poliomyelitis. Other cause of hypertension, that is drugs due to steroids and sympathomimetic, and dyselectrolytemia, that is hypernatremia and hypercalcemia. Causes of persistent hypertension. Renal cause, it is more than 75%, chronic glomerulonephritis 40%, chronic pyelonephritis 25%, congenital anomaly, polycystic kidney, obstructive uropathy, vesico-ureteric reflux, renal tumors, and the connective tissue disorders, there is SLE and Henox-Collin purpura. Renovascular hypertension, that is 10 to 20% in prevalence. Renal artery stenosis, renal vein thrombosis, 2 to 3% vascular cause, there is coarctation of aorta, aortoarteritis, and vasculitis syndrome, that is Hanox-Collin purpura. Endocrinal cause, there is a less than 1%. The Cushing syndrome, congenital adrenal hyperplasia, hyperaldosteronism, pheochromocytoma, neural place tumors, neuroblastoma, CNS disorders less than 1%. There is increased intracranial pressure. There is a brain tumor and hydrocephalus and familial dysautonomia. Essential hypertension or idiopathic hypertension in children, it is less than 10% due to the stress and obese childhood obesity. Which are the clinical manifestations of pediatric hypertension? Clinical manifestation of hypertension depends on severity, chronicity, and underlying cause. Essential hypertension in children, it is usually mild and asymptomatic, detected on a routine examination. Secondary hypertension may present with the features of underlying cause. If there is a renal disease, there is a growth failure, edema, and abdominal mass in case of Wilms tumor. Vascular cause, there is an unequal peripheral pulse, and the broods, there is a coarctation of aorta and Takayasu disease. And adrenal disease, there is obesity and virilization, and tumor, there is a weight loss and abdominal mass. Intracranial hypertension presented with headache, vomiting, dizziness, and convulsion, and presented as hypertensive encephalopathy, and there is an altered sensorium, seizures, and neurological deficit, diplopia, and fundal changes. There is a papilloedema on fundus examination. Cardiovascular stress presented with epistaxis, cardiomegaly, congestive cardiac failure, and renal failure. Fundus examination is essential in all the cases. An important retinal change in hypertension include generalized constriction of arterioles, retinal edema, flame-shaped hemorrhage, cotton wool spots denoting retinal infarct, and last is there is a papilloedema due to the chronic persistent hypertension. Features of long-standing hypertension, there is a thick vessels with silver wire or a copper wire appearance are rare in children. How to diagnose hypertension in children? Diagnosis of hypertension involve two-step process, confirm its presence, and etiological diagnosis. Step 1, confirming the presence of hypertension required repeated blood pressure measurement as follows. Blood pressure should be recorded in a comfortable setting with appropriate cup size, covering at least two-thirds of the upper arm and sphygmomanometer at a level of heart. BP should be recorded by auscultatory method with the appearance of first Korotkoff sound as an indicator of systolic blood pressure. And fifth Korotkoff sound, there's a muffling fourth sound as an indicator of diastolic blood pressure. Oscillatory or a palpatory method are unreliable. In infant, blood pressure may be recorded by a Doppler or a flush method. Since blood pressure varies with the age, body size, activity status, at least 3 readings on a different occasion, except in a very severe case, should exceed 95th percentile for the diagnosis of hypertension. In hypertensive children, blood pressure should be recorded in lower limb also. Normal blood pressure in a lower limb is 10 to 15 millimeter of mercury higher than upper limb due to more muscle mass and peripheral resistance. In coarctations of aorta and aortoarteritis, Takayasu disease, blood pressure in a lower limb is less than the upper limb. Step 2, etiological diagnosis depend on a detailed history and review of earlier case records where hypertension is transient or persistent. Physical examination for a feature of causative disease and relevant investigation. Depending on the probable etiology, plasma renin activity, there is a PRA, is a useful basic investigation in unexplained hypertension that differentiate renal and renovascular hypertension. Increased PRA from the other cause, there is a PRA is normal. In case of renal artery stenosis, there is increased PRA. Overview of blood pressure monitoring technique in children. Technique. Auscultatory, there is a mercury sphygmomanometer. Advantage, most evidence-based, non-invasive, quick to perform, and easily available. Which are the drawback of this mercury sphygmomanometer? White coat effect, that is observer bias, subject to the observer's skill and terminal digital preference, and safety hazards with mercury spill. Technique, there's an aneroid manometer. Advantage, there is easily portable, mercury free. Drawback, there is a need frequent calibration. Another technique, there is an oscillometric device. Advantage, easy to use, useful in infant where auscultation is difficult, not observer bias. And drawback, there is a limited reference data available. Value of diastolic pressure are derived from mean arterial pressure and may be inaccurate. Required repeated validation and cost and availability in case of oscillometric device. Another, there is a clinical blood pressure, there is an auscultatory and oscillometry. The ambulatory blood pressure, the auscultatory or oscillometric, there's an advantage, is a reliable normative data available. Detection of white coat hypertension or a mask hypertension and provide data on a diurnal variability. There's a nocturnal dip in a blood pressure. So reliable normative data for an oscillometric device. Drawbacks, limited number of breeding, white coat hypertension or mask hypertension monitoring, considerable cost, need for maintenance of equipment, required patient cooperation, training of relatives may cause anxiety and high chance of error in auscultatory device. Which investigation carried out in hypertensive child? The baseline investigation, there is urine analysis, specific for hematuria and proteinuria, renal function test, there is a blood urea and serum creatinine to rule out acute glomerulonephritis. Serum electrolytes, renal ESG, specific for congenital anomalies and obstructive neuropathy. And X-ray chase for a pulmonary edema, there is, in case of coit of aorta, there is a notching of ribs on X-ray chest. And ECG, specific for left ventricular hypertrophy due to hypertension in children due to cardiovascular cause. Selective investigation in case of pediatric hypertension, suspected renal and a renovascular cause, plasma renin activity increase in the case of renal artery stenosis. Uroimaging study, there is intravenous pyelography, micturitin cystoerythrogram, and the renal scan in to rule out renovascular hypertension. Renovascular study, there's a Doppler angiography and the renal biopsy, suspected vascular disease, and aortography and digital subtraction aortoangiography. Suspected endocrine cause, you should investigate urine and the plasma catecholamine for a pheochromocytoma. MIBG scan or a CAT scan or MRI to rule out neuroblastoma. Cortisol challenge test in case of Cushing syndrome. Urinary 17-hydroxyketosteroid in a congenital adrenal hyperplasia. And serum aldosterone in hyperaldosteronism. So what is the management about pediatric hypertension? The management of hypertension aim to keep the blood pressure consistently below 19th centile by specific antihypertensive therapy. There's a treatment of underlying cause. There's a surgical intervention in correctable renal, vascular, and neoplastic disorders. Non-pharmacological method, there's a salt-restricted diet, weight reduction, and exercise, which are more useful in essential than secondary hypertension, hence of a limited value in children. Therapeutic lifestyle changes, the weight management, weight reduction in overweight and obese children, dietary alteration, the prevention of excess of abnormal weight gain, increase in intake of fresh vegetables and fruits, and the low-fat dairy products, and dietary sodium restriction. There is a 2.6 to 3.8 gram of salts. There is 45 to 65 milliequivalent or 1 to 1.5 gram of sodium in adults. In adolescent, decrease in portion, there's a meal size. Reduce consumption of sugar-containing beverages, energy-dense snacks, regular meals, including healthy breakfast. Exercise, regular physical activity, at least 30 to 60 minutes every day, and the restrictions of sedentary activity. There is television watching, video, and computer games, less than 2 hours a day. Stress reduction, no specific recommendation likely beneficial. Others, smoking cessation and intervention to improve sleep quality in a recent scenario. Indication of pharmacotherapy in pediatric hypertension. A secondary or stage 2 hypertension. There is a pre-hypertension or a stage 1 hypertension associated with comorbid condition. There is a renal disease, cardiac disease, or diabetes mellitus. CDC, there's a stage 1 hypertension with end organ disease. There's a symptomatic hypertension, LVH, hypertensive retinal changes. And D, the stage 1 hypertension that failed to respond to the 6 to 12 month therapeutic lifestyle changes. Principle of treatment. The goal of treatment is a reduction of blood pressure level less than 19th percentile unless comorbid condition or a target organ damage present when it should be lowered to the 19th percentile. Commonly used medication in a children include AC inhibitors, there's angiotensin converting enzyme inhibitors, calcium channel blockers, vasodilators, beta blockers, and thiazide diuretics. Therapy is initiated with one agent at an appropriate dose, and the dose is increased until the desired blood pressure is achieved. If the highest dose is not effective, or if there are side effects, the drug from different class is added or substituted. So monotherapy is best. Medications with a longer duration of action, once or twice daily dosing, are preferred for a better compliance and the less side effect. Dose adjustment of any hypertensive medication need not made frequently than every 2 to 3 days. To start with, calcium channel blocker AC inhibitors Adrenergic beta blockers have a strongest data to support their use in a pediatric patient hypertension. A study suggests that AC inhibitors monotherapy was significantly more effective in controlling hypertension in children than calcium channel blockers. Oral antihypertensive medication. Angiotensin converting enzyme inhibitors. There is a captopril, enalapril, lamipril, angiotensin receptor blockers. There's a losartan, calcium channel blockers, amlodipine, nifedipine, and isradipine. Beta blockers. There's a atenolol, metoprolol, propranolol, and labetalol. Central alpha agonist. There's a clonidine. Peripheral alpha antagonist. There's a prazosin. Vasodilator, there is a hydralazine and minoxidil. Diuretic, there is a furosemide, spironolactone, metalazole, hydrochlorothiazide, and amiloride. Drug in treatment of hypertensive in emergency, that is sodium nitroprusside, labetalol, nifedipine, and glycerin trinitrate, and nicardipine and esmolol. Acute post-infectious glomerulonephritis. The treatment are sodium restrictions, diuretics, there is IV furosemide, and pharmacotherapy with calcium channel blockers, vasodilators, or AC inhibitors are a standard therapy to control transient hypertension in this condition. Chronic kidney disease, it initiates with AC inhibitors since these agents also reduce proteinuria and retard progression of the renal damage and give reduced dose if there is a 30 to 35% increase in a serum creatinine and there is a hyperkalemia. Therapy with either calcium channel blockers or alpha blockers is considered in severe renal failure when there is a GFR less than 30 per liter per minute, 1.73 per 20. So prazosin, labetalol, hydralazine, clonidine, minoxidil may be added use to control hypertension in chronic kidney disease. Renovascular hypertension. Treatment include angioplasty, surgery, and medication. Avoid AC inhibitors in a bilateral renovascular disease and use costlessly in unilateral disease as a drug acting on a renin-angiotensin axis may reduce GFR and precipitate renal failure. Initiate with calcium channel blockers or alpha blockers. In case of hypertensive emergency, may be associated with hypertensive encephalopathy presented with seizures, controlled reduction in blood pressure over 72 to 96 hours is essential. Rapid reduction can reduce perfusion, leading to organ damage. So decrease the blood pressure over 3 to 4 days. Treatment should be initiated with the IV drugs. Once the blood pressure is controlled, oral therapy can be started. It may be necessary to reinfuse fluid, particularly during the first 12 hours, to extend plasma volume. Should be blood pressure drop too rapidly. Controlled reduction of blood pressure is achieved by IV administration of labetalol and sodium nitroprusside. Esmolol is useful for a short-term use and a short duration of action. On a less severe case, nifedipine capsule can be used. In case of resistance case, diazoxide is given IV, but it can cause sudden hypertension. Other antihypertensive drugs which can be given IV include hydralazine and clonidine. Pheochromocytoma. The mainstay treatment of pheochromocytoma is a surgical removal of tumor. However, surgery should not take place until there's a alpha blockers are used first to control hypertensive episodes in pheochromocytoma. Once the alpha blockade is established, the tachycardia and heart irregularity may be controlled by cautious addition of beta blockers, and a cardioselective beta blockers is preferred. The pentoxybenzamine is a powerful alpha blockers, is effective in management of pheochromocytoma, but it has many side effects, and it may be given for a children 1 to 18 years at zero point 0.5 to 1 milligram per kg twice daily, adjusted according to response, and IV infusion at zero point 0.5 to 1 milligram per kg according to the response, occasionally up to 2 milligram per kg daily may be required. Do not repeat dose within 24 hours. Idiosyncratic profound hypotension within few minutes of starting infusion and convulsion following rapid infusion have been reported occasionally. So postural hypotension with dizziness and marked compensatory tachycardia, lassitude, nasal congestion, and meiosis are more commonly encountered. So what is the prognosis in pediatric hypertension? Prognosis secondary hypertension depends on underlying cause, duration, severity, and response to the specific therapy. While hypertensive encephalopathy or LVF are a common cause of immediate mortality, persistent moderate hypertension may lead to secondary organ damage after many years. Cardiomyopathy, retinopathy, nephropathy. Whether the children with essential hypertension continue to have hypertension in adulthood is uncertain. Today's my concluding remark, there's rational and effective use of antihypertensive in children and adolescent needs lucid understanding of approach to the diagnosis, identification of cause, and its use in emergency. Each condition associated with hypertension has a specific pharmacotherapeutic recommendation. Points to be remembered today's lecture: screening and early diagnosis and identification of the cause if hypertension in children is emphasized. Specific surgical and medical intervention is possible in a few instances. ACE inhibitors and calcium channel blockers may be used to initiate therapy in essential hypertension. ACE inhibitors is preferred for initial therapy for hypertension associated with chronic kidney disease, since these agents also reduce proteinuria, and retard progression renal damage. Initiate with calcium channel blocker and beta blocker in renovascular hypertension prior to the surgery and avoid AC inhibitors in a bilateral disease. Treatment of hypertensive emergency should be initiated with IV drug. There's a controlled reduction of blood pressure is achieved by IV administration of labetalol and sodium nitroprusside. Once the blood pressure is controlled, oral therapy can be started. Surgery for the pheochromocytoma should not take place until there is adequate blockade of both alpha and beta adenoreceptor. In 1980, in my study of this pediatric hypertension, one patient referred from Nadia to the VS hospital presented with paroxysmal headache, with irritability, with sweating on the forehead, with recurrent abdominal pain. And at that era, nobody doing this vascular work in radiology, but Dr. Madhubhai Parekh, he was doing this vascular work in radiology, and they helped me a lot for to rule out this pheochromocytoma case. Institution of lifestyle change and monitoring for the target organ damage and the drug toxicity is necessary on follow. Thank you.
Thank you so much, sir, for such a comprehensive talk and such wonderful insights that you have shared upon the topic. Thank you so much. We have received few questions, sir. With all your due permission, I would like to put it across to you.
Okay.
The first question that we have received is, what are the risk factors for oral contraceptive associated hypertension in children?
Risk factor for oral contraceptive.
Yes, associated with hypertension in children.
I do not find any case about this. There is a history of oral contraceptive. Then when I work for this pediatric hypertension in 80s, it may occur in case of adulthood hypertension.
All right. Thank you, sir. We'll move to the next question. And the next question is, what diet and exercise recommendations should be made for children with hypertension? What is your
I
view on
only
it?
told because in case of childhood hypertension, it is a secondary one. And most common is a renal. And in renal, it is acute transient hypertension. So the management is there's a salt restricted diet, diuretics, and antihypertensive like nifedipine. In case of children, there is a less than 10% case having obesity. It is more common in a Western country nowadays here due to the junk food, fast food, and processed food. There is a case also due to the stress on obesity. There is a do lifestyle modification. There is a healthy breakfast. Avoid the junk food, fast food, processed foods, salt restriction, and fresh fruits and fresh vegetables should take.
Thank you, sir, for answering this question. We'll move to the next question that we have received. And this question is, how are hypertensive emergency and urgency defined in children?
Most common emergency, there is when any child presented with puffiness of face, oliguria, hematuria, and presented with headache and vomiting. And it is the most common complication of acute glomerulonephritis. There is a hypertensive encephalopathy presented with sometimes there's a convulsion onto level of consciousness. The most common complications of acute glomerulonephritis post-streptococcal, there is hypertensive encephalopathies, acute renal failure, and acute cardiac failures. So management of choice, there is a first, there is a specific treatment, there's a diuretics and antihypertensive drugs. I already told there is a AC inhibitors, and also on when there is a hypertension is controlled within there is a 30 there is a 2 to 3 days, then put on a oral antihypertensive therapy, there is a nifedipine. Mostly in case of hypertension and also to control convulsion, use there is a lorazepam. Mostly in case of this hypertensive encephalopathy, do not require any emergency drugs because hypertensive emergency, there's a less than 5%.
Thank you so much, sir, for answering this question. That was the last question for today's session. And with this, I would also like to thank all the participants who have joined here with us and who have put up their questions to us. Thank you so much. And with this, I would also thank you, sir, for taking out your valuable time and for being here at our platform. With all the last comment, we can conclude the session here for today, sir.
So today's my concluding remark. There is a pediatric hypertension in children. It is a secondary hypertension. And the most common cause of secondary hypertension is a renal or renovascular. So it is acute and transient. And if it is chronic and persistent, presented with, there is a paroxysmal headache or irritability or a sweating or forehead, you should think about chronic persistent hypertension. There is renal artery stenosis, pheochromocytoma, coarctation of aorta, nephrosclerosis, chronic renal failure, and Wilms tumor.
Thank you so much, sir, for your valuable comment that you have added on. Thank you so much for your last remark. And with this, we would conclude the session here for today. Until next time, we surely will be meeting soon, sir, with a next presentation of yours. Thank you.
Okay, thank you to all. And also, once again, that I'm very thankful to IJCP group giving opportunity to highlight my views regarding my interesting topic. There is a pediatric hypertension.
Thank you, sir. We are concluding the session here for today. Good night.